This lecture is aimed to give you an overview of calcium disorder problems. Oh, she is not here. Are you going to take the board after residency? Yes? Okay, good. Can you unmute yourself? It would be an easier thing if we can communicate.
All right, all set.
Wonderful. Thank you so much.
Yeah.
Okay. So I call this review authentic because I do deal with calcium disorder patients starting in 1982. I don't know if you have been around at that time, but I wouldn't be surprised if I have too much experience. So along that, by now I know what to pay attention to. The topics I would like to share today would be divided by hypercalcemia or hypocalcemia. And when you have a problem with hypercalcemia, you have to decide if this is parathyroid dependent. It could be primary, tertiary, or inherited hyperparathyroidism. And alternatively, if it's PTH independent, meaning that the calcium is high, but the PTH is suppressed, low, then you have to differentiate between malignancy, cancer or lymphoma, granulomatosis or TB, and other less frequent causes like medication, endocrine disorders, CPN, Paget's disease, and stage liver disease. So that's for what we go over for hypercalcemia. And for hypocalcemia, we will touch on hypoparathyroidism, which is most frequently post-surgical, hereditary hypocalcemia, renal, and vitamin D deficiency. So these are the topics. And let's start with the symptoms. As it was demonstrated to me this morning as well, the symptoms are not dependent on mostly on the degree of hypercalcemia, but most of the time on the onset of hypercalcemia. So I had a patient with hyperparathyroidism this morning whose onset was this summer. And even though her calcium was generally just 10.5, she was full of symptoms. And the other patient who came with a calcium of 11.7 had absolutely no symptoms because his calcium is long-standing. Are you here?
I am, yeah. You might want to hit the enter presentation mode so your slides come along with what you're saying.
Enter presentation mode.
Yeah, bottom right.
How about if I just change the slide like this?
Yeah, I think that's just fine too, so I can follow along. Thank you.
Okay. So these are the symptoms. Thank you for reminding me. Changing slide is useful. The symptoms that patients mention are fatigue, irritability, and we do see coma in the hospital due to very high and relatively rapid onset hypercalcemia. We do see nephrogenic DI, which usually leads to dehydration. Patients can't stop urinating. They have renal insufficiency. As a result, they can have GI symptoms, including constipation, it's the mildest, or they can develop ulcer pancreatitis. They frequently complain of bone pain, and when we measure bone density, it shows bone loss. They complain of muscle weakness, and they can present with cardiac arrhythmia. And the higher the calcium, the shorter the QT interval. So I like to have EKGs on patients when I am consulted for hypercalcemia. I normally examine my patients, and my symptomatic hypercalcemia patient today had these big nails. She complained that they are brittle, and the hair loss that's depicted here. And after the exam, I ordered testing. So I took history. I do the physical exam. Most characteristically, hyperparathyroid patients have tenderness at the forearm, 2/3 up, and other PTH-independent hypercalcemia patients don't have this. I order lab tests. The most useful ones are PTH, don't forget phosphorus, PTH-related peptides, 125 dihydroxyvitamin D, ACE, renal function, FGF23, SPEP, urine calcium, hormone levels, TSH, cortisol, ACTH, and metanephrines. Imaging includes a bone survey to look for brown tumors. One is depicted on the right, and localization studies that includes ultrasound, nuclear medicine, parathyroid sestamibi scan, and 4D CT. This is the parathyroid-dependent hypercalcemia. I put this cartoon here to show that calcium under the influence of PTH is coming not just from bone resorption, but also from kidney reabsorption. So when you treat it, you have to facilitate loss of calcium through the kidney and intestinal calcium absorption, and what regulates the feedback. So when you have hyperparathyroidism, you just don't have feedback regulation on the parathyroid. It keeps secreting PTH despite high calcium. That indicates a defect in calcium sensing receptor, either from an adenoma that became autonomous or from a genetic defect or antibodies against the calcium sensing receptor. So here is a case report of a really challenging hyperparathyroid patient who presented in 2019. She did not have too many symptoms, except she had back pain and fatigue. She recalled treatment-resistant vitamin D deficiency over 5 years and history of hepatitis C. And she had no medication history that would account for the high calcium. Namely, she did not take hydrochlorothiazide, PPI, lithium, or vitamin A. Her laboratory tests were notable for serum calcium 11.3, low 125 hydroxyvitamin D at 23, PTH ranging from 117 to 280 picogram per milliliter. Her serum phosphorus was 2.2, and her urine calcium was elevated at 450 milligram per 24 hours. And repeatedly, these values remained in this range. What really indicates that she has primary hyperparathyroidism is the low phosphorus. Up to phosphorus of 3, it's more likely to be primary hyperparathyroidism. If the phosphorus is above 3, It's most likely some form of either hyperplasia or secondary hyperparathyroidism. Her bone density was not very remarkable. She had some osteopenia. Her QT interval was not very prolonged or very low. Imaging was non-localizing. To be misleading, the neck ultrasound showed a hypoechoic nodule in the right thyroid, which after surgery turned out to be just a thyroid nodule, and the sesame-based scan did not show any retention. And the 4D CT did not reveal anything in the neck, but the proof of the hyperparathyroid workup is surgery, and a really good parathyroid surgeon did not find any parathyroid pathology in the neck in January. But you never give up. So after the surgery, I repeated the laboratory testing, and it showed the same hyperparathyroidism. And imaging showed nothing in the neck as expected with ultrasound. But on second look, on 4D CT, they spotted a parathyroid behind the clavicle, right clavicle. So it was hiding behind the bone. And the repeat nuclear medicine study after 1 more year showed the retention at this 1 centimeter parathyroid adenoma, which was successfully removed, and the patient is doing wonderfully. The hyperparathyroid is resolved. And these are the localization studies I mentioned. The nuclear medicine study shows the retention. The ultrasound is the most sensitive to show behind the thyroid adenomas, and the 4D CT is lighting up in the arterial phase where the parathyroid is, and darkening in the venous phase for parathyroid. The forearm bone density is pretty sensitive to differentiate between primary and secondary hyperparathyroidism. For primary hyperparathyroidism, the lowest score is at the 1/3 radius, and for secondary hyperparathyroidism, the lowest score is at the mid-region. So based on this, you can also predict which one the patient has. I recall a young lady in the hospital, 30 years old, who presented in her second trimester of pregnancy with hyperemesis, and her serum calcium was 13, the phosphorus was 2.4, and the PTH was 147, and the neck ultrasound showed a 3.5 centimeter right inferior parathyroid adenoma, which was removed since she was in the second trimester with urgent surgery. If this would not have been removed in the second trimester, then the baby would have severe hypocalcemia after delivery. Most of them don't live more than the first day, and they fail to develop parathyroid if there was no surgery involved. The reason for such a young patient to have hyperparathyroidism is usually a hereditary disease, either MEN1, MEN2, or hyperparathyroid jaw tumor syndrome. In addition, you can spot other endocrine or non-endocrine tumors, and you would memorize the pituitary, parathyroid, and pancreatic, the three Ps. And the first presenting abnormality is usually the parathyroid. But you have to check out at least prolactin and insulin level to rule out multiple endocrine neoplasia. And we frequently also take metanephrines for neuroendocrine tumor. Patients with familiar hypocalciuric hypercalcemia can come with typical symptoms of hyperparathyroidism. Even they can come with fractures like this baby or child showed rib fractures. And this just highlights the importance of taking urine calcium. And if it's very low, usually less than 60 milligram in 24 hours, then this is indicative of FHH, and the treatment is not parathyroidectomy, even though they have enlarged parathyroid. And the cause is an inactivation of the calcium sensing receptor. They may or may not have family history. And the treatment is cinacalcet, which resets the set point of the calcium sensing receptor. For primary hyperparathyroidism, you have to do surgery, basically. The treatment is always surgical. You try to locate the abnormal parathyroid. In very rare cases, if my patient was over the age of 90 or really, really sick with comorbidities, then you can opt for either observation or the cinacalcet again. Another hypercalcemic condition is what we see after renal transplant. If the hypercalcemia persists over 2 years, then they are referred to me for evaluation of tertiary hyperparathyroidism. And this is due to elevated FGF23 during the renal insufficiency phase, which persists and suppresses the renal calcitriol production. And this leads to hypophosphatemia. And due to the low phosphorus, you have persistent hyperparathyroidism and increased calcium. And this is a table to show you how you differentiate between primary and secondary hyperparathyroidism. And the two things that are very characteristic are the serum phosphorus, which in primary, again, low. And in secondary, it is the high bone turnover in primary and normal most of the time in secondary. Well, we arrived to the PTH-independent hypercalcemia, which includes malignancy, cancer, or lymphoma. The two mechanisms that are involved are excess PTH-related peptide secretion. This hormone is coming from the tumor and acts on the normal PTH receptor and generates the same kind of hypercalcemia. And the alternative is bone destruction by the tumor or lymphoma. In granulomatosis or TB, you have ectopic active vitamin D secretion driving the hypercalcemia, naming that it's a reabsorptive or absorptive hypercalcemia. And under the other, you really have to ask for offending medications. Most of the time, hydrochlorothiazide or lithium, look for endocrine diseases, hyperthyroidism. You can look around in the room. If TPN is hanging, that could be the reason for the hypercalcemia. End-stage liver disease, I just had one in the summer with very significant high calcium, unexplained by anything else. And Paget's disease is getting rare, but it could also present with hypercalcemia. Now, when you go to the board, this is how they present you the question. They show you this chest X-ray. They most of the time don't show you the macrophages, but they will give you the laboratory test values. 125 hydroxyvitamin D elevated, ACE elevated, calcium elevated, PTH low. So can you tell me what this is? Hello, Adam. Hi.
I guess it would be PTH-independent hypercalcemia, right?
Yeah, but what is the reason? You can see it on the chest X-ray.
The nodule kind of there in the, I guess that'd be probably like right middle lobe potentially.
Yeah, it's sarcoidosis. This is how sarcoidosis looks like. Okay, this was a young 34-year-old guy who presented with a non-healing right leg ulcer. I was consulted by the limb service, and rheumatology was seeing this person for 2 years. And meanwhile, he developed hypercalcemia, which recently became symptomatic. And no wonder his calcium was 15. Phosphorus was again above 3, it was 3.5. The PTH was suppressed at 9. PTH-RP was normal, and 125 dihydroxyvitamin D was elevated at 154. Everything else was normal. He was very somnolent, dizzy, had palpitations. And this is an example how you treat it. You hydrate first and then give Lasix. And then you do the chest X-ray like on the previous slide, and it showed the typical granulomatosis nodules. And he had an inguinal lymph node that can be biopsied that was also showing granulomatosis. And the treatment started with 40 milligram prednisone, and he went home with normal calcium. And this is another how it would be presented in the board. This would be the pelvis X-ray with a serum calcium. It's a female with a serum calcium of 14.5, a PTH of 5, and the PTH-RP with a normal limit of less than 2 is here 59. Would you guess what the diagnosis is? Please.
Yes, I'm guessing a malignancy would be the first thing.
Pardon?
Say a malignancy.
Yeah, which one?
If it's female and it's hypodense lesions.
And high PTH-RP?
I guess either maybe lung cancer or breast cancer.
No, it's breast cancer.
Breast cancer.
Yeah. Lung cancer does not give these type of bone-destructive metastases.
Gotcha.
In the pelvis. So if you are hit with this question, now you know what to say. Okay, this is another form of non-PTH dependent hypercalcemia that I see interestingly very often in the clinic. in avid exercisers. So it's due to muscle damage. If they run the marathon or half marathon, they lose so much calcium from the muscle that it gives them significant hypercalcemia and hypercalciuria. You can also get myopathy, pretty severe, from autoimmune diseases, immobilization. If the patient is bedbound for more than 3 weeks, you get hypercalcemia. It's not rare. What's rare is the autoimmune dermatomyositis or polymyositis. I don't see that much, but I do a good share of statin-induced myopathy. It can be pretty severe, and it's relatively slow to heal. So you think that you stop the statin and next day the patient no longer has muscle pain, change your perspective, patient will start improving probably in 6 weeks. So don't be misled by that. It's a frequent question on statin-induced myopathy. And this is the Paget's disease that you diagnose with nuclear medicine bone scan. And in severe form, it can present in the bone. But you have to remember that the bone is disorganized. So you don't have the normal structure. You see how it's all over? Nothing really differentiates the cortical bone as the other. And this is how you manage the hypercalcemia. One of the interesting things that I frequently have to say, that if you refer me a patient for hypercalcemia, for God's sake, stop the calcium supplement. You don't know how many times this comes. And then you look for lithium hydrochlorothiazide, and you have to stop that. And then you have to hydrate with 3 liters of normal saline first. And after that, you can start the Lasix. If you start the Lasix first, you would just aggravate the prerenal azotemia and the nephrogenic DI, and you would get a person with significant volume deficiency. Then you can start right away injecting calcitonin, 200 micrograms twice a day. That increases the urinary loss of calcium and blocks the calcium coming out from the bones. So all those metastases won't allow you to have high calcium. You can then give anti-resorptives only if it's PTH independent and the patient preferably shouldn't have renal disease, and you can give pamidronate. That will work for 3 weeks. You can give Zometa. They are both nephrotoxic. The Zometa will work for 3 months, and at the end you can give denosumab that is much better than the bisphosphonates in terms of effectiveness, and that will work for 6 months. As we discussed, you can give steroid if it's sarcoidosis or other granulomatosis. Cinacalcet for dialysis patient or FHH. You can mobilize the patient. And if you get desperate and nothing helps and the patient is comatose with acute kidney injury, you can always use plasmapheresis or dialyze it out. So that's your ultimate go-to. Well, we are making progress, so we arrived to hypocalcemia, and it's not midnight yet. So you have to decide if this hypocalcemia is acute or chronic. It can be asymptomatic or severe. And there are multiple causes. hypoparathyroidism, vitamin D deficiency, intestinal malabsorption. Don't be surprised if your small bowel transplant patients or patient with colectomy doesn't have enough calcium. Some of the patients take excessive magnesium supplements. I had last week a patient with copper problem, Wilson's disease, and some of the osteoporosis or cancer treatment also comes with hypocalcemia. Should we go through the Shostak and Trousseau? Say yes or no?
Sure, why not?
Okay, so you tap on the nerve coming out from the foramen, and that's the Shostak sign. And as you can see, the corner of the mouth is twitching up. And the Trousseau sign is when you pump up the blood pressure cuff and the patient makes this corpus pedal spasm. Is you see probably how abnormal the fingers look like. Would you remember this?
I do, yeah.
Okay. Now, in mild cases, it comes with irritability or paresthesias. In severe cases, you can get seizures, tetany, laryngospasm, and cardiac problems. Hypoparathyroidism is usually a long-standing cause, except when you have a patient with parathyroid surgery. It's not necessarily long-standing. They can recover in 2 weeks. So you may or may not have to worry too much about the post-surgical. If they don't recover, you have to treat it. You have the hereditary forms, autoimmune, and parathyroid resistance syndrome. That's fun and publishable. This is the surgical hyperparathyroidism. It depends on the thyroid surgeon. They either give you a hypocalcemia every week with almost every surgery, or they hardly ever give you hypocalcemia patients. My patients never get this problem because I pre-treat with vitamin D. So if they are vitamin D replete, they don't get hungry bone syndrome. And if you give a transfusion to this post-surgical patient, then you surely will get hypocalcemia. This was a memorable patient at NIH where a post-surgical hypoparathyroidism got untreated, basically just replaced with active vitamin D. And the patient also took phosphate enemas for constipation and developed this basal ganglia calcification. Since then, I had multiple of this when long-standing hypoparathyroidism leads to excessive neurological damage. It could make the patient unable to walk, unable to write or read, and develop Parkinsonism and impaired memory. So just because a patient presents to you with Parkinson's, please check the calcium. It could be hypoparathyroidism. This is the DiGeorge syndrome that they will ask you about. And the mnemotic is catch-22, and it comes with abnormal facial features, thymic aplasia, immune deficiency, cleft palate, and hypocalcemia. They look like leprechauns. Would you remember the ear? This flipping ear, that's how you recognize, even if it comes at age 78. And it's due to a deletion in 22q11.2. And this is the Albright hereditary osteodystrophy with the short fingers, short stature, and this is a GS alpha deficiency with high PTH, but there is no PTH action. So they sometimes come with mental retardation, and the patient that I recognize that has this is the osteomas. It's like in the scalp, two bony horns come out under the skin. That's very characteristic. And finally, we come to a very frequent reason for hypocalcemia, which is vitamin D deficiency. This is the Boeing leg. You might want to remember. I thought that it only exists in Africa, but this morning I saw a lady with such severe vitamin D deficiency that she had her legs bowed and painful. And this is because she never goes out due to the COVID, and she is just watching TV along with my grandchildren. And if she would ever go out, she surely would use sunblock. And it could generate these loser zones, which is a transverse fracture of the bone. That's painful. And if you do a biopsy, you get a non-mineralized bone. And they typically have muscle weakness, knee pain, arm pain, impaired immune function. So it's all over the press now that they are more susceptible to COVID-19. And it's best to replace it. And when you replace it, I highly recommend that you give the human form of vitamin D, the cholecalciferol is D3, because it's self-regulated in the liver, and you can keep giving it. It will never cause toxicity and will sustain a good level of vitamin D. If you give vitamin D2, the level will soon decrease after 2-3 weeks. You are back to where you were, and most of the time your symptoms don't improve. And there are hereditary forms of inability to metabolize the vitamin D in the liver or in the testes. And this is the vitamin D receptor defect. I had a nice collection of about 30 patients from the Middle East when I was at NIH with this hereditary vitamin D deficiency. They show signs of rickets. They don't start walking. They have the bowed legs, and frequently they don't grow hair, because to grow hair, you need vitamin D receptor. It's a board question. So remember, no hair. This is the X-linked hypophosphatemic rickets. I have a couple of patients. They break their bones so frequently that they are full of rods in their bones. Before we got the borosozumab, and now it's perfectly treatable. Crysvita is available, and they stop having pain and normalize their phosphorus level. They would not tolerate enough phosphorus replacement because it gives them GI symptoms, very profound diarrhea. So it's worth getting the prior authorization for borosozumab. So after that, there is a similar cause is the tumor-induced osteomalacia when the tumor secretes FGF23. The borosozumab treatment for this is not yet approved, but I hope that I can get it for my patient who presented today with tumor-induced osteomalacia due to prostate cancer. And hypocalcemia management traditionally was done with calcium and calcitriol replacement, which leads to a very high urine calcium and nephrocalcinosis. And the symptoms are not really resolved. And nowadays we give PTH derivative, Forteo or Natpara, and patients are doing wonderfully, and the vascular calcifications and brain damage and eye calcium deposits and renal impairment all prevented. So you need to do that. This is the treatment, the PTH. If they ask you on the board, don't choose the calcium calcitriol, choose the PTH, the Forteo or Natpara. And we accomplished to review hypercalcemia and hypocalcemia board problems. And I hope you take home some good tips and might have some questions for me as well.